Hi, this is Brian Kim. I'm going to share with you case number 75 in the best way to do cataract surgery series. This is a patient who has a small pupil and a soft lens. And so you'll see the standard double chop, cross chop, and really how I'm able to efficiently and easily disassemble this lens despite the smaller size pupil and despite the soft lens. So I'm using a cotton tip to help center the eye. This patient has a strong Bell's reflex. And then I'm using the corneal mark, which will help me to center and size the rhexis. I'm turning the eye towards the left, make a small incision on the right side, and then on the left side, these are my paracentesis incisions, which I've made parallel to the iris plane, which helps to create a nice corneal shelf, which will allow me to achieve a self-sealing incision. I'm injecting some intracameral lidocaine and then some intracameral epinephrine to see if I can dilate the pupil a little bit more. It really didn't help much. So I'm injecting dispersive viscoelastic to fill the chamber and to coat the corneal endothelium. This will be the triplanar corneal incision. I make a vertical groove and I place the blade into the deep part of the groove, tunnel through the cornea, and then when I'm ready to enter, I turn the eye towards me using the cannula, I dive down. And that's the triplanar incision. I'm pushing some more viscoelastic to fill the chamber, and then I'm going to do my puncture style rhexis. I'm puncturing the center, and then I'm pulling down towards me, grabbing the right side of the tear, which will create a flap. And in this case, since the pupil is on the small side, I'm able to use the pupil as a guide for my rhexis. I'm going around circumferentially, very carefully, trying to stay fairly within the confines of the corneal marks that I made previously. So I finish off the rhexis, burp viscoelastic from the anterior chamber, and this is now the capsular fornix hydrodissection technique. I place the cannula out underneath the rhexis edge contra-incisionally, point the tip down, get a nice fluid wave here. I'm very careful with these small pupils because you don't want the iris to come out when you do this. So I go ahead and do it again, and I got the wave. It was a slow moving wave, and I had to do it twice there. Sweeping on the left side, turning the tip down on the right side, and I'm able to hook the lens and it starts to spin nicely here. Go ahead and irrigate the surface of the eye and turning the sleeve to the appropriate length. Lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. Remove the surface epinuclear material. Place the chopper underneath the rhexis edge contra-incisionally, pointing the phaco tip vertically sub-incisionally. Bringing both instruments together in the center, crushing and bisecting the lens in half, that is the double chop. Placing the chopper around the right heminucleus, pulling it centrally towards the phaco tip, crushing and bisecting the right heminucleus, that is the cross chop. Turning the lens in front of me, the second heminucleus, placing the chopper around the lens piece, bisecting it in half, and then placing the chopper around the adjacent quadrant, pulling it centrally, crushing it as well, and then slowly and carefully emulsifying the lens pieces. You can see this is such a soft lens. As I was breaking it up, a lot of the lens pieces were coming out. Rotating that lost quadrant in front of me, placing the chopper around it, pulling it centrally towards the phaco tip and crushing the lens piece, using a little bit of vacuum to grasp the lens piece, and then crushing it even further into smaller pieces. grasping the small pieces with the vacuum and then crushing it into smaller pieces. We're grasping the epinucleus from anterior to posterior, and it starts to tumble out of the eye here through the phaco tip. I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I start subincisionally, removing the cortical material, grabbing the anterior component first, and it tumbles out pretty easily here. Switch to the other side, starting subincisionally and going around circumferentially. I can tell there's some cortical material that's still adherent to the posterior capsule here. Once all the cortex is out, I switch to polish mode, polishing underneath the rexus edge, looking for any cortical material and sweeping the lens epithelial cells. I'm going to go in with the BSS cannula, pulsing underneath the rexus edge subincisionally here. And in this case, it looks pretty clean. So go ahead and inject the cohesive viscoelastic to fill the bag. And I'm going to go ahead and polish just a little bit underneath the rexus edge here. I'm going to inject the single piece acrylic intraocular lens into the capsular bag. You want to make sure the bag is completely filled, so the leading edge of the lens goes within the bag. While the lens is unfolding, I switch to the INA quickly, go in with irrigation off, activate irrigation, tease the haptics off the optic, and then I'm going in with the Maltzman, which will help me to check that the lens is indeed within the bag and not in the sulcus. So I can see the rexus edge there, and it's definitely within the bag. I rotate the optic 90 degrees, going under it with the INA tip, and then I'm tilting it using a two-handed technique with the INA tip as well as a Maltzman. And in this way, I am confident that the lens is completely in the bag. I reposit the lens back, again checking by retracting the pupil, switching to polish mode, removing some more of that lens material from underneath the rexus edge, and then rotating the haptics horizontally. Once the lens is in position the way I want it, I switch to visco mode, removing all the viscoelastic from the anterior chamber. And I have the Maltzman there just in case the iris gets in the way while I'm trying to do my manipulation, like here. I see some fine material that's adherent to the posterior capsule, and so I go underneath the lens with the INA tip, switch to polish mode, and remove that material. So I switch back to visco mode, start to remove the rest of the viscoelastic from the anterior chamber. You can see the iris is vibrating here, so probably a little bit of a floppiness to it. I push BSS with the cannula, being very careful, making sure that the iris doesn't come out when I go out with the INA handpiece, and then I hydrate my incisions. So again, this is a smallish pupil, soft lens. You can see how easily I'm able to disassemble the lens using double chop and cross chop. Again, sculpting a soft lens ends up just falling apart. Difficult to crack once you've made a groove with these lenses. Very difficult to impale the lens for vertical chop with this type of lens. And so really, again, a lot of techniques work with cataracts, but in my opinion, the best technique is the one that you don't have to switch depending upon the type of lens you have. And double chop, cross chop is really a very versatile technique that can be used on all types of cataracts and all different size pupils. So I hope this was helpful to you, and I thank you for your attention.